Chronic hypoventilation impacts posture and stability, especially for women with autonomic disorders. Stay tuned because today you will discover how to identify signs of dysfunctional breathing and evidence based breathing retraining protocols. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute and your host on the Virtual Neurology Summit. The purpose of the Virtual Neurology Summit is to provide healthcare professionals with brain based solutions to get better neuroplastic results with your patients. I'm honored to welcome our next guest expert. Dr. Tatiana Habanova is a board-certified chiropractic neurologist and functional medicine practitioner with 25 plus years of experience in neuroperformance, hormone balance, and concussion recovery. She founded Palm Beach Brain Center to help individuals restore cognitive function, navigate hormonal transitions, and build long-term neurological resilience through personalized brain-based care. Today, she'll be sharing with us From Breath to Brain, sex differences in respiratory neurodynamics and their impact on gait and cognitive function. Dr. Habanova, thank you so much for joining us as a speaker on the Virtual Neurology Summit. Please take it away.
All right, well, I was very excited about doing this topic for the Neurology Summit this year. And I think it was just one of those things that movement is so important, so necessary for cognitive function, so necessary for just moving around planet Earth and having a quality of life. But sometimes, some of the simplest things can be the most powerful things. And so I'm very honored to be able to do this topic on identifying the sex differences, so between men and women, and their neurodynamics of respiration, and of course, how that's going to impact things like cognitive function, gait, balance, stability, etc. So already Dr. Burns has introduced me. So I am a board certified chiropractic neurologist, a founder of the Palm Beach Brain Center, and I have the pleasure of working with patients on a variety of different topics. A lot of brain-based care for women, as that's an area of expertise and specialty that I enjoy. So today we're just going to do a quick little overview, diving deep into the weeds a little bit, but also providing some implementation that you're going to be able to do immediately in terms of making a difference and how to identify some of these respiratory differences that women present with, and a lot of times might be even slightly hidden. So one of the things I'm really kind of empowered by actually is the idea of taking something super small, and as these tiles are showing, it's just like a tiny little thing, but that ripple effect which is going to make a major impact. And that's what I think respiration really is for us. A lot of times respiration is just thought of, well, breath work, it's we hear it all the time, we breathe all day long. But did you know that breathing is really the only autonomic nervous system function that we can consciously control? And obviously, it occurs unconsciously. Right now, we're probably not thinking about our breaths as we're sitting here listening to this conversation. But when we do want to influence our breath, we have that top-down ability to be able to influence it consciously. And what's most powerful is that it really is our gateway for rewiring the brain. And so I hate to be kind of cliche about it because we all breathe. Obviously, breath is important. One of the three major neuro necessities of the nervous system is oxygen, number one, fuel, and then stimulation. So we obviously can't go without breath or oxygen for very long. But let's not forget how powerful the action of breath, the action of breathing, and the neurological elements behind all that, how powerful it is for a form of neuroplasticity. So really not to kind of give you the, punchline of my whole presentation and the whole take-home message, but really utilizing breath is such a major powerful tool. And I hope in these next 20 minutes, I will convince you, if you haven't already been convinced, to convince you even more and to bring some highlight on the differences to women's breathing patterns compared to men's breathing patterns, as science has recently provided more evidence for that and for us to understand that as clinicians. And then when a woman does come into the office, working with you clinically, for this maybe to come to top of mind for you to say, hey, maybe I need to quickly evaluate her breathing patterns just a tad more to see if she's falling into that general predictable pattern. So every breath we take will send a signal to our nervous system that's going to be honestly shaping, believe it or not, our breath, and how we choose to breathe is going to shape our posture, our gait, our attention, even our hormonal balance. Now, I'm not going to get into a lot of the functional medicine stuff today, since we'll be focusing on functional neurology, but just a little thing to keep in mind as well. But yeah, many of us are actually breathing wrong. I mean, you think you just inhale, exhale, and don't really have to put much more thought behind it. But unfortunately, there is a little bit more thought that has to go behind that. And thankfully, we could retrain that for our patients. And so I'll teach you about that towards the end as well. Simple, easy techniques that you can do in the office, and ways to teach this for home care as well. So especially under times of stress or brain injury, even during hormonal transitions, breathing patterns do change. So those are another markers that you might want to consider if you're working with someone who has recently had a brain injury for various reasons, going through any type of hormonal transitions, or just under stress on a daily basis. That's going to impact us in a big way, both men and women, but particularly a little bit more in the women. And how so? Because studies have shown that 60 to 70% of women habitually are breathing in their upper chest area, something that we would call apical or thoracic breathing, as opposed to what we're usually more familiar with and hearing about is diaphragmatic breathing. So I know these words have been thrown around probably a lot. Most people are probably very familiar with these ideas, but sometimes maybe not taking the recognition of how important it is to circle back around and look at that neurodynamics of breath and how that can impact a lot of things. So we'll get into the neuro here in a second and tie those pieces together on how breathing influences posture, gait, and cognitive function. But specifically under times of stress, after brain injury, anytime we're having any type of dysautonomia, anything that's occurring in that lower brainstem, this is where we're going to want to circle back around and consider what is that breathing pattern of the person, especially if they're women. So altered breathing patterns are going to change our vagal tone. We're going to end up having compensatory movement patterns. And over time, this will have impact on our gait, stability, our balance, as well as our cognitive performance. So let's talk a little bit about the sex differences, just so you can be able to delineate that. Basically, structurally, so look at structure and look at function. Structurally, women tend to just generally have a shorter, more narrow, more rounded rib cage than men do. Men tend to have a little bit more deeper and a wider rib cage. So you think, wow, really? Is that going to be that big of a difference? And this is also aligned with same height and weight. So men and women that were same height and weight, it wasn't that men are just larger and bigger, maybe women tend to be a little bit on the smaller frame. No, even on same size and weight, women still will have more of a narrow and rounded rib cage. And what that really translates to is that women are actually just getting about 10% less lung volume than men. So that's really important. You think, well, what's that big of a deal? Is it really that much? But it is. It really does end up influencing a state of chronic hypoventilation in women. So as we look at we're looking at more a breath work where women's rib cages are more vertically orientated, that's going to be causing a little bit more of a pump handle kind of breathing or an apical upper chest breathing mechanism, just the orientation of those ribs. And this is all due to the morphology to the thoracic spine, and why men tend to have more horizontal ribs because, again, how they attach onto the spinous processes. So, the transverse processes. Men are going to end up having a little bit more of what we consider that bucket handle, where they're opening wider and lower into the rib cage as opposed to elevating it through the upper chest. So that's really basically the major differences from the structural perspective. But from a functional perspective, what apical breathing or shallow breath, now men can sometimes fall into this as well. I do see that with my male clients as well, more predominant with the female clients. And I can say that clinically, I can see that. And the research is also indicating that for women. But what that apical breathing pattern is going to end up leading to is this chronic state of hypoventilation. So this is going to end up creating a sympathetic dominant state, a reduced vagal tone. And from there, we're just going to have a downstream effect of poor posture, balance, instability, gait alterations, and basically compensatory movement patterns overall. And then that will have its influence on cognitive performance. So with diaphragmatic breathing, that actually kicks us into a little bit more of a parasympathetic state. The use of the diaphragm is going to allow for more core stabilization. So not just from the diaphragm itself, although that is a major player, obviously, but all the way up through the postural muscles of the spine. And then we're going to have much better gait, balance, etc. So, just the way a person chooses to breathe, how they choose to breathe, a lot of that is unconscious, and people aren't even aware, obviously, of their breathing patterns. And sometimes we get into breathing patterns under times of stress, obviously, we get a little more worked up, but also brain injuries. That's where people don't even realize they've altered their breathing patterns. They're still breathing, they haven't passed out, so life should be okay, correct? But we also know with brain injuries that a lot of times there's a decreased stride length. And that decreased stride length, just a small amount, the person won't even feel like they're walking slower. But just that little difference also will take at least 10 years off their life. So here we can say, well, is that decreased stride length? Where's that coming from? Let's bring it back to the beginning and say, well, maybe that's coming from that neurodynamics and a change in breath. And let's go ahead and see what we can do to empower the client, alter that breathing pattern, and then move the needle forward in improvements. So why is this important? Well, I've already delineated some of that, but things to consider with these, chronic hypoventilation effects, right? And this downward spiral, as we discussed. So literally, I kind of almost scare my patients a little bit into making them realize how important breathing is, and that they should become conscious of their breath and invest time into improving their breath. And I dedicate time in my office with their visit when they come to do breath with them. And I am taking those 5 minutes, 10 minutes, maybe, depending, because I want them to know that it's that important, that powerful, and for them to get into the habit of it too. So what are the hidden costs of chronic hypoventilation? And that really, that sentence there really gets their attention. So feel free to use that in the office if that resonates with you. But that's kind of how I open that conversation up. And their ears kind of perk up. So I'm like, all right, I got a few moments there to get some powerful messages across. So chronic hypoventilation basically is a state of shallow breathing. As we discussed, women tend to do that more because the ribs are vertically aligned. They're breathing up into those upper rib area, and they're not expanding. Remember, we're the lower lung field. So the lungs are divided into thirds. The lower lung field is a significant portion. I kind of guesstimate at about 50% of the whole lung volume. Don't quote me on that. That's just a generic visual that I give patients so they understand that half of their breath needs to go down low. And that seems to kind of click the idea. And most people believe their lungs are up here. So when you actually demonstrate to them and you ask them to find the bottom of their rib cage and tell them that's the bottom of their lungs and demonstrate that it's pretty much the lower torso, now they start to realize that there's more to their lungs. You obviously all know that already. So, all right. So basically, the chronic cost of hypoventilation is kicking into a more so sympathetic state due to those breathing patterns, causing a dysregulation of some of those baroreceptors and changing our heart rate variability, changing orthostatic tolerance. This is where Dr. Burns mentioned about patients who have dysautonomia and how important when we're trying to untangle dysautonomia and perhaps a larger umbrella of POTS and the various conditions that fall under that, and looking at a variety of autonomic findings, right? We do respiratory rate, but we also want to be looking at the quality of their breath. We do heart rate variability. We do heart rate, right? We're doing blood pressure. We're doing orthostatic testing from laying down to standing up, and we're looking at all these variables change, but are we analyzing how they're breathing, not just the number of times that they did breathe? So all of that generally is going to be leading to that poor vagal tone. We'll connect the neural bit here in a second. And of course, that's going to lead to poor posture, changes in their ability, possibly even dizziness, depending on that orthostatic intolerance and the baroreceptor response, and of course, some instability. So let's get into the neuro part, the fun stuff. So some of the key findings to a very important area, of course, where all of this leads to is the pontomedullary reticular formation. So PMRF, as it's known for short. And think of the PMRF as this neurological bridge. It is spanning, obviously, the pontomedullary portion of the brainstem, and it is going to be that bridge and that connection for breath, right? Then balance, movement, and consciousness. So just as a reminder, a couple of things that happen here in the PMRF. Respiration is obviously the big key component we want to talk about. The medullary respiratory centers are there, and they generate a rhythmic breathing pattern. This is going to be done through the phrenic nerve, and this will be on the dorsal respiratory group here on the backside. You'll see here that the vagus is connected to that. So and our pacemaker cells, also another important area in the ventral respiratory group that's going to be creating that rhythm. Okay, and we know it's so important from a neurological perspective. There's a lot of rhythms and timings, and so it's really important that we're really allowing the PMRF to be well trained in that sense. And how do we train this area is through breathing, right? Through effort breathing, and eventually that'll become unconscious and it'll follow that rhythm and its timing, right? So there we go, it becomes automatic. So these areas for the respiratory aspect of the PMRF are going to adjust their breathing patterns in response to metabolic demands, right? Emotional states, because we're going to get some top-down influence from the limbic system that feathers down into the PMRF. So that will have a change. And then postural changes, as we discussed, with from sitting to standing or bending over and all the different things people do in life. So this is obviously very important for movement, the ability for these respiratory centers to adjust their rhythm, their breathing patterns to the movement, the dynamics we're doing during sleep as we fall into a deeper state, right? As well as when we're trying to recover from any type of brain injury. Our reticular activating system is another important area that is here. So that's for arousal and consciousness. This is going to go all the way up into the thalamus and help to regulate our attention, alertness. Okay, our sleep-wake cycles are also in the PMRF. So again, another important aspect of just regulating consciousness, sleep states, breath, breathing, as well as cardiovascular regulation, and of course, swallowing, as we see here with the vagus and the glossopharyngeal nerve. So a few other things that are important here is, of course, in the PMRF, we also have motor control. So this is going to be the source of where our reticular spinal tracts come from. So for voluntary and involuntary movements, this is important in things such as gait, right? Walking, postural changes, reflexogenic actions. So again, motor centers live in the PMRF, breathing centers live in the PMRF. So this is all very important that we keep this area very healthy and strong. Postural integration, we're going to have input from the vestibular system, proprioceptive input as well, feathers into this area, and that's going to help not only adjust our muscle tone, but also in response to gravity, our orientation in space and how we need to adapt our posture accordingly. And of course, we're going to have this area as well for rhythmic limb movements in the, that's a tongueful. In terms of for our locomotion, again, in terms of gait and that rhythmic movement. So you can see that there's a lot that happens in the PMRF, and I probably haven't even done it full justice, just given some of the big picture areas to consider. So again, this area is that neurological bridge where bringing in vitality and improvement and neuroplastic changes through breath is going to influence all these other areas that are also housed in the PMRF. So that's an important consideration when you're looking at someone's overall brain health, vitality, and protocols when you're working with people. So how breath will regulate posture as in gait. Again, just a summary slide if you just want to kind of delineate everything into one place. So again, looking at breathing, our balance, gait, all into the brainstem. These medullary respiratory centers are going to create that rhythm, okay? And they're going to influence the vestibular system. We know that influences our posture and movement. And basically, we want to get into diaphragmatic breathing, which is going to allow for much greater stabilization through the diaphragm, through the postural muscles of the spine, allow for deeper core activation. And that, of course, is going to bring about better balance, gait stability, and obviously mobility as we move through planet Earth. So in women that have dysfunctional breathing, this is now where you want to start identifying, does the patient in front of me, especially if there are women, that little light bulb goes off a little bit more, so let me evaluate, does she have dysfunctional breathing? Because most likely then she's going to have low vagal tone, which you could also assess, and you can triangulate those ideas together. And of course, looking at postural instabilities, seeing how she's doing there and however you assess the posture, and looking at gait, right? So some of this can easily be done from the bedside. So let's go ahead and take a moment and look at some of those clinical signs on what you can be doing as a checklist to see, hey, do I need to consider, involving a breathing retraining program within her clinical care? So some clinical signs of dysfunctional breathing, these are some red flags that are commonly missed. So first and foremost, double check. Does she have apical breathing patterns? Just take a look and see. Do you see that upper chest elevation? Is she using accessory respiratory breathing muscles? Take a look at overall her posture, as this image is indicating. Most likely there'll be an anterior head carriage. There'll be that lordosis in the lumbar spine. We'll have a little bit more of a kyphotic lordotic or a hyperkyphotic lordotic posture. Is there also paradoxal breathing or reverse breathing? So if you don't pause for a moment, and sometimes you might not want the patient to know you're doing this, sometimes you do, so it's your decision, but taking a look, so does the abdomen pull in on the inhale? Okay, so those are kind of things to look at. Sometimes people don't even realize they're breathing sort of opposite to the stream. Do you see a lot of sigh, yawning, breath holding, and very importantly, mouth breathing? I'm going to challenge you. Take a look now, maybe for a day, play the game, and just observe mouth breathing. And you will probably find it in a lot more people than you realize. A lot of times it's disguised because people might be talking or whatever the case is, but there is a lot more mouth breathing going on. I've seen that tick up in my clinic. I don't exactly know the source of it. I have a few guesses of what may be bringing that a little bit more to fruition. Maybe I'm just being more aware of it. But either way, I challenge you to consider it. You'll find that most people are doing more mouth breathing than before. Air hunger. This is where they start taking some really, really deep breaths in. So those are things that we want to be looking at. If you start saying that really exaggerate air hunger, it's not necessarily a yawn. They're trying to take air in. All right. If they have poor tolerance to walking or talking and walking, so that's always a good talk test. Take them for a little bit of a walk and see if they can keep a conversation at just a regular pace. And then obviously, do those symptoms worsen if they're under stress or they're multitasking? Are they having any other, complaints that they're bringing to you? Now, a couple little things that you can do from a functional medicine perspective, if you're getting blood work done or you're getting it from their physician or whatever the case is to take a look at the carbon dioxide level on blood work. It will probably be low. I generally see these in about the 20s and 21s. That's a common place. We want them to be 25 to 30. All right, that's the functional range. The lab range will be different, obviously, but functionally we want it in that range. So that's another little clue if you happen to see some blood work. You can also take a tape measure and just measure their rib expansion. Sometimes it's also called rib excursion. So right at the level of T6, you're just going to ask them to stand. They could sit, but I tend to do it standing. Hands are to the side. You put the tape measure around and you just measure what that is. And then you just ask them to take a deep breath in and just follow that measurement. And then that's the number you want. And then you ask them to exhale. Okay. So you're really looking at that expansion and you want a 1.5 to 3 inches of be able to open up the lower lung fields. Okay, so that's a really simple 1 second, maybe 1 minute assessment to do in the office. And it also is a nice objective finding because patients a lot of times will feel, I'm breathing fine. I don't feel lightheaded. I don't think I have problems with my breath. But when you show them that they're getting less than 1 inch, which is the common finding I have in my practice, I get excited when someone's at 1.5, but that's just basically the bare minimum of that norm, right? So that should be super excited to be about, but at least they made it into the norm. So I'm thrilled for that. But generally it is around the 1 inch or under. So again, test that out in your clinic. Get back to me. Let me know if those are your findings as well. The other thing you can do is we can have them laying down. You can palpate the edge of their diaphragm, so along the lower rib cage. And what's going to happen is if you press in during inhalation, so you're just going to go ahead and dig your fingers in a little bit, careful with the fingernails. So gently with the pads of the fingers, dig in a little bit and ask them to inhale. And what should normally happen, and let's practice this right now. So if you're doing this at home, so just go ahead, dig in, and we'll just take a nice deep breath in. And if you feel your fingers push out significantly, that's awesome. That means they're belly breathing. But when you ask them to inhale or you do it yourself and you inhale, and there is literally barely any movements of your fingers, well, that is what we have diaphragm inhibition on palpation, and that's what that means, okay? So that's another simple way that you can even teach people to evaluate themselves at home, and another quickie, maybe if you're doing the abdominal examination or you just want to do that as your test. Okay. So a couple things to think about in terms of, is it brain-based or is it breath-based? Like what's going on here? So if someone comes and say, I have brain fog, I feel dizzy, well, there may be a little bit of vasoconstriction going on in this, the cerebrum, right? So is there maybe this lack of blood flow and perfusion that might be occurring? Anxiety. There's been a lot of research indicating obviously the power of breath and the improvement of vagal tone to anxiety. That as well documented into the research. So again, if they're talking about maybe having anxiety, panic, irritability, we know that there's not enough oxygen getting into the brain. You can definitely look at that through a Bolt test if you do that. So blood oxygen level test, you'll take a deep breath in, exhale it out, and then hold and start your timer. And you're holding. And ideally, someone who can tolerate a decent amount of carbon dioxide is 40 seconds breath hold, basically. So if someone can make it to that, then you know that their carbon dioxide balance is doing good. Their vagal tone is good. There's not a dysregulation there. If they can't do that, then there's probably something to work on. They feel fatigued. Maybe they're wired by tired. They're probably, again, doing that apical breathing. They're getting that poor oxygen delivery. Maybe sleep disturbances at night. There might be some mouth breathing going on there. So again, another thing to consider, maybe a sleep study, possibly if they are perhaps even getting sleep apnea, maybe some mouth taping perhaps to help with that. And then just take a look at their overall posture. If you're seeing that typical anterior head carriage, rounded shoulders, slumped posture, already there's an issue with the PMRF. So again, breath is a very powerful place to start with that. So just real quick, I'll give you 2 seconds of an example I had in a patient. I've actually written about this in the concussion discussions book that I contributed a chapter to. And this was actually that patient. So I'll give you a quick synopsis here. 46-year-old menopausal woman complains of the typical complaints that we might see of someone in that age group and postmenopausal sort of, so brain fog, common brain fog. She did have some palpitations, lightheadedness, a mild form of cognitive decline. Did do a MOCA on her, and she's just right there on that border between subjective and mild cognitive impairment, but definitely complained about focus, attention, and memory issues. And she's felt that that was sort of unusual for her. Just thought it was just getting old. So she already had workups for post-concussive syndrome, MS, POTS, looked at anxiety, looked at the thyroid. All of that really came out, non-conclusive. Nothing really stood out. But when we looked at her posture, she definitely had the typical apical breathing posture, as opposed to a much better diaphragmatic breathing posture. So, all right, there's an indicator there. She had this, every time she would lay down, she'd be one of my morning clients. And every time she laid down, she would do this air hunger yawn. It was every single time. And I thought it was just maybe she was a morning person, because she was one of my first early morning clients that would come in to see me. Not necessarily for brain-based stuff initially. I was seeing her for some other things. But every time she ended up laying down, there was that big air hunger yawn. And I just was like, okay, we need to evaluate this. So upon evaluation, sure enough, diaphragm was inhibited upon palpation. So as she was taking that deep breath in, I had my fingers along her rib edges and my fingers weren't moving. So she definitely was not breathing through her diaphragm. And she definitely had exaggerated heart rate responses with postural changes. So we had that orthostatic intolerance. So bottom line, it really just ended up that she just needed to be taught how to breathe properly. And upon taking those 2 weeks to train breath, wasn't huge, just took some dedicated time, made it a goal. We made it a team goal together. And all of a sudden, a lot of those symptoms just started decreasing. She started to get more oxygenated, and the PEMRF actually became more stable. Like neurologically, it improved, which improved so many other things. So it wasn't really that her nervous system was, an issue, but it was that she was breathing. And had we continued, like the most important thing for me, I'm so glad we turned that boat around for her, and it was a simple fix, right? Something that she had to take action over, and something she has to be very aware of how she continues to breathe. Now we want to build this up so it becomes so automatic that she doesn't have to be conscious about her breath all the time, right? That could be very taxing and difficult in life, and it's not how it's supposed to be. So we need to continue with that from a neuroplastic perspective. But if we didn't catch it, can you imagine what her life would have been 10 years from now? Where would she be neurologically? Not in as great of a place. So that's what's more powerful for me. What can you do for rebraining techniques? Well, breathing is really the neuro rehab's untapped tool. And if you're not doing 2 to 5 minutes of breath training with your clients on a regular basis, your patients, I'm going to encourage you to start doing that. You will see significant improvements, and all your other protocols will start working even better. So I know you're probably a rock star already, but if you want to just take it up another notch, breathing is the fastest way to access the brainstem without drugs or devices. So super easy to implement, huge differences in the cortex, brainstem, etc. So simple, easy. We could just go ahead in a seated position, lying down position, whatever works. You could just easily put one hand on the chest, one on the belly, as the picture indicates, and allow people to just gently breathe in and breathe out, allowing them to feel their breath. That's the key here, is to feel the breath, to be aware of where breath is occurring. You've coached them already to be diaphragmatic breathers, not apical breathers, but now giving them a chance to experience that and using the hands as guidance there. Okay, so just that alone will start to kick them into a parasympathetic state, and we'll see a lot of changes. Heart rate variability will improve, posture focus, and things like this. I like to do this, especially when some of the clients that come in that are a little bit wound up, so they're kind of just, maybe they had a busy day, maybe that's just their personality. So really trying to reduce that cortical hyperarousal so that I can have a more beneficial session in my brain-based sessions with them. So again, that's why I say I make it important in my session. It's one of the first things we do with everybody. They start to get into the habit and routine, knowing this is what Dr. Habanova is going to do in the first 5 minutes of my session. And they're already, after a few sessions, they get it, and they start already kind of getting ready to do it. And if many times when I walk into the room, they're already doing it. So I'm like, excellent. I like to see that they're taking charge of that. Another thing that you can do could also be even more powerful. So kind of maybe a couple next steps is to do right brain, left brain breathing, or lateralized breathing. And I do this a little bit more in terms of the cognitive domain, but obviously can be done at any time. This is taken through yoga. And there are 2 versions. The basic version is you're just going to be nice and comfortable, however you want to be. And you're just going to close off one nostril. You're going to breathe in. Let's say we close off the right nostril. We're going to breathe in through the left nostril. And what I like to do is I like to visualize that breath going to the opposite cortex. So I literally imagine air going in and I have it cross over. And then you're going to close that nostril and exhale out. So if we close the right nostril, breathing in through the left, close the left, and breathe out through the right. Then we start again. Now we'll breathe in through the right and breathe out the left. Okay, so we just keep going back and forth like that. And all that's considered one. Now it's done nice and slow, obviously, and focus. I'm just doing a little quicker here. But you really want to just take that time and allow that air to kind of go up into the cortex and come all the way back out. Now, if you want to add a little bit more advanced version, so something you can progress to, okay, that's really fine. Patients like that, is to be able to now retain the breath. So lateral breathing with breath retention. So you'll close off the right nostril. So sometimes people will sometimes put their pointer on their, between their eyebrow, and they're kind of toggle between their middle and their thumb just to make it easy. Sometimes people actually will literally change. It's up to you, whatever works. So you're going to breathe in through. So we're going to occlude the left, breathe in through the right nostril. We're going to hold, and you can determine that, how long you want that to be. And then we're going to exhale and breathe out through the left. And then we'll repeat that again, the other side, to complete the cycle. Okay, so you have those options with the breath retention. The ability to allow for the different hemispheres of the brain to come up into some sync. So this is, again, yogi kind of world, but there is some science behind that as well. I've given you some references that you can research more if you'd like to know a little bit more behind that. And we're going to be improving that cognitive function, mental clarity, and motor skills. So I tend to save this breath work, this lateralized breathing with the retention or not, for when I'm doing more cognitive performance or cognitive recovery. but you can choose how you wish to use that. So what are some things that you can do in the office that are super simple? You can take those 2 to 5 minutes. You can start every session with priming the brain, reducing brain noise, just starting to maybe even synchronize that breath work. You can do it with your patients yourself. You can have your tech do that, or you can end the session with breath work as well, just to kind of consolidate all the gains, reintegrate the autonomic nervous system, and kind of remind the patient that that's sort of the breathing method that they want to come back into. What are some other things that you can do as well if you don't want to be stationary? Well, you can do it with gait training. You can start progressing breath work with the swing phase. So inhaling through the swing phase, exhale through the strike phase, right? The heel strike phase. So you can incorporate things like that through balance tasks. You can breathe in and breathe out through various aspects there. And if you're doing some seated therapy, maybe if you're doing some eye-hand coordination work, you're doing even some cognitive rehab, there's a lot of different ways you can incorporate breath, and that becomes more challenging. Just so be prepared for that when you do it that way. There's other things that you might want to consider, and I've recently started integrating a lot more virtual reality into the practice. And a nice, easy way, if you want to start with virtual reality, is to do breath work. So the neuro breath work used through the VR headset. What's really nice about this is there's really nice immersive environments. They take you a million different beautiful places. So you really do feel transformed, into another world, which maybe sometimes patients need to get out of their head like that and literally be taken elsewhere. Very peaceful, calming environments. Patients love this. They're super engaged. A lot of that distractibility and all that noise in their head really does reduce. You can also watch in real time what's happening with their breath, their pace, their depth, their rhythm, etc., like that. And again, allowing patients to feel their breath internally. This is the big key here, okay? So with the hand positions, of course, but also just really kind of sensing more of their breath and their ability to control breath and the power they have around that, okay? Very calming, very soothing environments, things like that. You obviously can layer it if you want to do that. So this is just really an amazing, excellent patient approach with concussion, chronic stress, dysautonomia, people who really struggle, this is the key here, with breath control or regulated breath in open settings, right? So sometimes, and then being in that enclosed environment, you put them in a nice comfy chair, something relaxing in a quiet room, right? So you really create the environment in your office for this. They put the headsets on and all of it just takes them to a whole nother level. If you haven't tried this, I'm going to encourage you to consider, testing it yourself, and you'll know what I mean. So just a quick little demonstration. There are a variety of different ones. Here are two that you can choose that are at low cost to you. This first one from AVR Well, they are a lovely company. They're coming out with this breathing app, and they have many scenes. This one I liked a lot. I thought it was fun. They play a little Hawaiian music in the background. You feel a little bit of that ocean breeze. And then as you're inhaling and exhaling, you're following along basically. And you can adjust you can do 4 breaths in, hold for 4, exhale out, the 4x4. They've got a lot of different breathing styles there. Now, this other one I thought was really interesting too, Flowborn. So when you have the headsets on, you're going to have your controllers. And what they do is they put the controller on your belly. So what you're going to see out of the gate here, do you see that little controller? Hold on, let me stop that. Oops, hold on. Oops, sorry, not fast enough. Let me go back. Hold on, going back. There, let me stop that. Stop. Okay, right at the bottom, one of the controllers turns into this little round green thing, okay? And what that is there it is, okay? So you can see that. Now, what it's going to do, it's going to feel your belly moving and your belly breath, okay? So now what happens here, and I really like this one because when you inhale, you don't move. But when you exhale, you start moving through this underwater caves. There's lots of scenes. I just chose this one through these underwater caves. So I'm going to play it just for 2 seconds so you can see a little bit. So we're not moving. So I'm breathing in. You can see I'm taking air in because the bubbles are there. But then I exhale and flowers pop out and all this wonderful, beautiful things happen and we move. We move. Now we're slowing down, taking a breath in. So you can see kind of, and now I've exhaled. I'm exhaling and we're moving. Now, the longer you exhale, the longer you're going to move. So on this last one here, I think I took a really long exhale and we're really going to make it all the way to the other side. So you just exhale, 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 exhale. Oh, I guess I did maybe one more. I think I took 4 breaths. Hold on, last one. And exhale. And so the patient is in control of this. And you just keep going, keep going, keep going, keep going. So that's really a lot of fun for them to have that movement and to feel the power of their breath and then have some fun things happen. So anyway, some things if you want to integrate into the office, the key here is to really take a look at your patients, look if they have dysfunctional breathing. We know women majorly do, 60-70% of women do. So pretty much most women are going to require a breathing retraining program, 2-3 minutes in your office on every visit. So thank you very much for your time. I'll give it back to Dr. Krista.
Dr. Habanova, thank you so much for your excellent presentation. Really great clinical takeaways, and thank you for performing that demonstration there at the end. That's so exciting. I think we can see great ways of implementing breath retraining. So you started by saying movement adds quality to our life. Respiration makes a large ripple effect for function. Only autonomic function, so respiration is the only autonomic function that we can consciously control and can influence it with conscious top-down mechanisms. So major neuro necessity, we have oxygen, fuel, and stimulation. So we have to make sure that we're getting that adequate breathing for oxygenation. Utilizing breath is a powerful tool for neuroplasticity. Every breath taken sends a signal to the nervous system impacting hormonal balance, posture, gait, and attention, especially impacted by brain injury, stress, and hormonal transitions. So recognizing if your patients are in those states that they could be particularly impacted. And then 60 to 70% of women habitually breathe in their upper chest area, referred to as apical breathing, especially under stress, leads to altered ribcage mechanics, poor vagal tone, and compensatory movement patterns. Over time, impacts gait stability, balance, and even cognitive performance. So looking at the anatomical differences between males and females, structurally, we see that shorter, narrower rib cages for females, and female ribs are oriented more vertically. Women have 10% less lung volume, and females tend to display more of a pump handle motion. Women elevate into their upper chest. And functionally, apical shallow breathing leads to chronic hypoventilation, contributes to chronic sympathetic nervous system output, reduced vagal tone, and poor postural control. With diaphragmatic breathing, it leads us more into a parasympathetic nervous system state, with core stabilization during gait and balance tasks. Looking at chronic hypoventilation effects. So hypoventilation in the autonomic nervous system, it's a downward spiral. So chronic hypoventilation leads to shallow breathing plus low oxygenation and poor O2 regulation, leads to reduced vagal tone and sympathetic nervous system dominance. Vagal dysfunction impacts baroreflex sensitivity, HRV, and orthostatic tolerance. Low vagal tone is linked with poor postural adaptation, dizziness, and gait instability. So key functions of the pontomedullary reticular formation, it's a neurological bridge between breath, balance, movement, and consciousness. So with respiration, we have medullary respiratory centers that modulate breathing rhythm via the phrenic nerve, and they adjust breathing patterns in response to metabolic, homeostatic, and emotional stress. And then arousal and consciousness, so part of the ascending reticular activating system, projects to the thalamus and cortex to regulate attention, alertness, and consciousness. And then the sleep-wake regulation, so contributes to transitions between sleep states and wakefulness. Other autonomic functions like cardiovascular regulation. And then with motor control for the reticulospinal tracts for voluntary and involuntary movements, and coordinates muscle activity and muscular shifts. For postural control, integrates vestibular and proprioceptive input for adjusting muscle tone, and locomotion initiates and modulates rhythmic limb movements. When it comes to breath, it regulates posture and gait. So the medullary respiratory centers for rhythm, vestibular input influences. Poor breathing can lead to shortened strides and impaired balance, and women with dysfunctional breathing and low vagal tone will have sympathetic nervous system amplification and postural and gait instabilities. So looking at our clinical signs, performing tests for apical breathing patterns, looking at paradoxical or reverse breathing, sighing, yawning, or mouth breathing, chest tightness and air hunger, poor tolerance to talking while walking, symptoms worse under stress or multitasking, low CO2 on blood work, the low functional range, rib expansion with a tape measure, and then doing diaphragmatic inhibition on palpation, so checking for inhibition with palpation. And then brain-based or breath-based. So neurologic indications would be things like brain fog and dizziness, anxiety and fatigue, sleep disruption, and postural instability. Breath-related will be hyperventilation leading to cerebral vasoconstriction, CO2 imbalances, and plus vagal dysregulation, which we can do the Bolt test, nighttime hyperventilation and mouth breathing, and then poor core and diaphragm engagement leading to gait changes. And the PMRF can become more stable with respiration training, so that can have an impact on so many other functions as well. And so, when it comes to breathing retraining techniques, breath affects cortical excitability, brainstem function, and autonomic nervous system regulation. It's the fastest way to impact the brainstem. With diaphragmatic control, feel where the breath is, improve HRV and posture, and then reduce cortical hyperarousal. And then lateralized breathing for cognitive recovery, right brain, left brain, alternate nostril breathing, and then visualize breath going into the cortex. I like that visualization component as well. And then progress to lateral breathing with breath retention. So for low cost implementation, adding 2 to 5 minutes of breath retraining at the beginning or end of a session, cue breathing with gait training and or with balance training. So if you want it to be more active, and then also virtual reality. I love this implementation. So neuro breath work through VR headsets. It's an immersive environment, enhancing patient engagement and reducing distractibility. So you shared with us some great resources there for that virtual reality. Dr. Habanova, thank you so much for this excellent presentation. Couple of questions for you, if you don't mind, before we wrap up. My first question is at what point with breath retraining do you feel that it actually becomes automatic for your patients? And I know it's going to be patient specific based upon, their case history, but how often do you have them focus on their respiration throughout the day between visits? And then when would you say it goes more into an automatic state for them to have retrained breathing patterns?
That's a great question. I think honestly, once they can start having a little more mobility in their rib cage, which of course, using the diaphragm and thinking about those lower ribs really funneling down to the hips. So giving them that visual where literally that will start happening when they can start feeling more mobility in the thoracic spine, rib cage. That will better help integrate the breath. So really, when we can get to that point, generally, muscles will take about 4 to 6 weeks, no matter what you do, training wise, for any muscle. So I would say, on average, I say to people, it takes generally about 4 to 6 weeks for this to start to become autopilot. I do see improvements in the first 2, 3 weeks, though, and definitely those patients that are being more diligent about it. So I encourage them throughout the day to take some dedicated time, like we said, to do that. But I also encourage them that, breathing is something we do every second of every day. So we're like brushing our teeth, we do it maybe a couple times a day, right? So we need to be practicing this breathing method more throughout the day. And I find the patients that do that do make changes a lot quicker. So it's literally just the amount that they choose to do. So how do I say that? Well, when you're driving, maybe when you're standing at the grocery store, like there's all these little moments throughout the day you can take 15, 20, 30 seconds and just integrate some breath work. I find that helps quite a bit.
Wonderful, thank you. And then last question, when it comes to mouth breathers, especially mouth breathing at night, do you recommend the mouth tape and have you seen beneficial effects from it?
I do. I mean, obviously, you want to screen if they have sleep apnea, and if that's the case, you need to send them out for a sleep study to confirm that diagnosis, obviously. But I do find the mouth taping helps. There's a variety of different ones on the market. Some people are a little claustrophobic, so I find some of the ones that are just X tape, so they have a little gap on the side, helps. And I really do find it gives some kind of control. I know it's probably not conscious since you're sleeping, but there is something there that promotes them to start nasal breathing. And we know the benefits of nasal breathing versus mouth breathing are huge. So I don't think it takes that long for them to start to realize. In fact, they kind of start forgetting to use their mouth tape. And I use that as an indicator of that they're doing better, on that realm.
Excellent. Thank you so much. And as we wrap up another great session today in the Virtual Neurology Summit, I'd like to acknowledge Dr. Habanova for her excellent work in functional neurology. And to all of our viewers, I'd like to acknowledge you. Thank you for your commitment to brain-based correction and objective clinical results. I'm Dr. Krista, your host of the Virtual Neurology Summit. Be sure to check out the Postural Neurology program to get certified in brain-based postural correction. Stay tuned, and we'll see you on the next Neuromasterclass of the Virtual Neurology Summit.